Okay, I hit go live.
Hi, everyone.
Wait, you're not live yet.
Ooh.
I'll let you know when.
Says live.
You're good.
Hi, everyone, and welcome to NOCC's Facebook page. We are here today to talk about tumor testing and what that means. It's about a minute before 4 o'clock, so I'm going to hold off. We just wanted to make sure that we were able to go live. So hang tight for about 30 seconds, and then we will start. All right. Let's go. Good afternoon, everyone. My name is Alana Feuchter, and I am the Senior Manager for Patient Advocacy with the NOCC. I'd like to welcome you today as we discuss the subject of tumor testing. We are pleased to have Sonja Alexander as our expert of the day. Sonja is a medical science liaison with Foundation Medicine, supporting providers with education, awareness, research related to comprehensive genomic profiling. Prior to joining Foundation Medicine, she practiced as a nurse practitioner for over 10 years in women's health, with the majority of her time spent working with gyn-onc patients at Mercy Medical in Baltimore. She has a postmaster's from Duke in oncology and is a certified advanced oncology provider. Sonja has a lot of information to share with us today. And as she's going through her slides, if you have questions during her presentation, please type them in the comment section and we will do our best to answer them at the conclusion. I will now hand it off to Sonja. Thank you.
Thank you for that wonderful welcome. I'm going to go ahead and start sharing my screen and we'll get the presentation going. All right. So thank you to the NOCC for inviting me to be part of this exciting live virtual series. I appreciate everyone taking the time and tuning in. My disclosure is I am an employee of Foundation Medicine. Let's start by going back in time to our high school science class days and talk DNA and genes. A genome is all living things genetic material. It is the entire set of hereditary instructions for building, running, and maintaining an organism and passing life on to the next generation. Cancer is a disease of the genome. It starts with a change in the genome of an individual cell that allows that cell to divide and grow uncontrollably. It usually is not possible to know exactly why one person develops cancer and another does not. But we do know that certain risk factors, like smoking related to lung cancer or ultraviolet radiation exposure relating to skin cancer, may increase a person's chance of developing cancer. Exposure to these risk factors may cause somatic mutations. These mutations are acquired after birth and are present only in the cancerous tumor. Somatic mutations are the most common cause of cancer. These mutations occur from damage to genes in an individual cell during a person's life. Cancers that occur because of somatic mutations are referred to as sporadic cancers. Somatic mutations are not passed from parent to child. My talk this evening is about discovering these somatic mutations in cancer. Another grouping of mutations you may have heard about are germline mutations. Germline mutations are far less common. Inherited or hereditary cancer accounts for 5 to 10% of all cancers. It is recommended all ovarian cancer patients undergo genetic testing either by a blood test or saliva test for BRCA, BRCA mutations, a known hereditary risk for ovarian cancer. Targeted therapy is a cancer treatment that uses drugs to target specific genes and proteins that are involved in the growth and survival of cancer cells. Targeted therapy takes into account that each cancer is unique. Even among patients with a single type of cancer, such as breast cancer, there are many different types of disease, and each has characteristic genomic changes. A provider would need to know these tumor characteristics, for instance, ER positive or HER2 positive, to best treat that unique cancer. For ovarian cancer, we have treatment options specific for BRCA or BRCA positive patients that involve targeted therapies. In some cancers, such as lung, there is a movement away from putting all lung cancer patients in one large bucket and treating them on the organ-based diagnosis of lung, to putting lung cancer patients into smaller buckets based on the genomics or unique characteristics of their cancer and treating them with a targeted therapy. So a shift away from a one-size-fits-all model to a more personalized model of care. In some cancers, targeted therapies are utilized at the time of diagnosis versus standard chemotherapy, with potential less harm to normal cells and potentially fewer side effects. Once a candidate target has been identified, the next step is to develop a therapy that affects the target in a way that interferes with its ability to promote cancer cell growth or survival. As we continue to make advances and strides in cancer genomics, more and more targeted therapies are becoming available to cancer patients. How can we identify patients who may respond to targeted therapy? While specific guidance does not yet exist to inform exactly which type of test should be used in every clinical context, Foundation Medicine is the first FDA-approved broad companion diagnostic with Medicare coverage for qualifying patients across all solid tumors, including non-small cell lung cancer, colorectal, breast, ovarian, and melanoma. Although some metastatic cancer patients are receiving some form of tumor testing, only a few receive comprehensive testing. As illustrated by these wonderful NOCC fact sheets, ovarian cancer is one of the most malignant gynecologic tumors associated, sadly, with high mortality and high reoccurrence rates. Over 70% of women are diagnosed at an advanced stage, attributable to no screening test, vague symptomology, and lack of awareness of this silent killer. Therefore, ovarian cancer patients could benefit from testing to determine a patient's tumor genomic profile and potential for use of a targeted therapy. For many, many years, there was very few treatment options for ovarian cancer patients, with PARP inhibitors, a form of targeted therapy, making a grand appearance in 2014. There's been a lot of excitement and research into adding additional targetable therapies to the ovarian cancer space. What exactly is involved in tumor or somatic testing that leads to the option of precision medicine? A request for testing is completed by your provider, and then a pathologist needs to select and prepare tumor tissue removed from a biopsy or surgery to be sent for testing. Sometimes there is abundant cancer cells present, like in an ovarian cancer surgery or debulking surgery, and other times in lung cancer, ensuring adequate cancer or tumor cells can be challenging. This is a key step into ensuring successful testing. Next generation sequencing, or NGS, performs sequencing of hundreds of millions of small fragments of DNA in parallel and essentially mapping the individual reads to the human reference genome, looking for variations or differences that might signal cancer. This technology has come leaps and bounds from where it started, but it is still a very involved process that takes time. There is a lot of scientific magic that happens between sample preparation and clinical reporting that on average can take approximately 2 weeks. Sequencing, analysis, and interpretation involves a team of scientists to ensure the most accurate report is delivered to the provider. The reports, or as I like to call them, tumor portfolios, contain detailed information that can be several pages long. They will include things like FDA-approved therapy, biomarker information, pertinent negatives based on cancer type to help rule out therapies that are unlikely to work, therapies with clinical benefit, and potential clinical trial information. Immunotherapy is a popular therapy option for some cancer patients, and the report includes information in the form of biomarker that providers need to make beneficial treatment decisions regarding immunotherapy. While there are no specific guidelines that say when to test for all cancers, next-generation sequencing is being used at various points in a patient's cancer journey. In the ovarian cancer patient, next-generation sequencing is commonly used at the time of diagnosis and or with reoccurrence, depending on the provider preference. Thank you for your time. I hope you've learned something that is helpful to you or a loved one. I'm happy to take any questions or comments.
Thank you so much, Sonja. That was super, super thorough. Oops, here we go. There I am. That was super, super thorough. And in fact, I see a lot of positive thumbs up and and hearts that people enjoyed it, but I don't have any questions at the moment. So let's give everybody just a few more minutes and see if perhaps they're just digesting that information and then going to come back with some questions. So everyone, I've got some thank yous. So Amy Spinozzi says thank you. And Deborah Hartman says great education. So wow, I think you were amazingly thorough. Let's give it a few more minutes. Sure. I know sometimes people are really digesting what was said. And especially if you are like me, you don't have that science background and you're kind of learning on the fly. It takes a lot to.
And this is something new to providers as well. We're learning and the science is changing every day. So, you know, it's a complex topic and very fluid.
Yes. So are there any mutations that you would be looking at besides a BRCA mutation that might influence an ovarian cancer patient's treatment at this point?
So there's several that are similar to breast cancer patients, like the BRIT mutation or CHEK mutation. But the more patients that we test, the more is added to that big data and the more we can learn about mutations that might be specific to ovarian cancer. And when we locate those mutations, that's when we can try to appeal to the pharmaceutical companies to make some targetable agents that would match those mutations. So, you know, although sometimes patients may have testing done that doesn't reveal a perfect match for a targetable agent, that information is being added to our big data so we can try to, in the long run, help ovarian cancer patients.
So that's a very good point, that if you perhaps don't find out something unique for you that can help you use targeted drugs right now, you would be able to perhaps in the future with more data collection.
Right.
We did have another question, a couple other questions.
Great.
One is, what labs are doing tumor testing?
So there are several different vendors that are available that would complete tumor testing. It's comprehensive tumor testing or next generation sequencing. So sometimes it's in the form of what we call hotspot panels. Lung cancer is very known to have these specific genes they're looking for that would be completed as a hotspot panel. But what we do at Foundation Medicine is do a comprehensive genomic profile. So we're looking for any potential mutation, whether it was something that might have been seen in a lung cancer patient or a brain cancer. If there's a targetable medication that's out there and that's what's driving your cancer, we're hoping to be able to match you to that. So we don't want to limit what we're looking for. We want to search that whole genome, trying to find any potential matches. So that's a key difference to ask is what kind of panel it is. And then also, I think the important thing is that FDA approval that we have to show that our science is validated and that we're able to repeat that same test over and over and get those accurate answers back to the provider.
Excellent. A couple other questions for you. How far after original testing or surgery can testing be done a second time, or even a first time if you've been treated? Does it change over time?
That's a great question. So from what we know, if you have a standard chemotherapy, the tumor will not change. So you can have potential testing done on that original sample. So if you had surgery, your standard chemotherapy, and then had a reoccurrence maybe 1 or 2 years later, and for some reason they, a biopsy is not obtained, they can use that original surgical specimen as long as it's just been standard chemotherapies. Now, in lung cancer, where you can get a targeted agent upfront at the time of diagnosis, you might develop alternate mutations or resistance. So you would want to repeat testing on a fresh sample if you were to have a reoccurrence.
That's a great answer. Let's see. I think we already answered this. Other than BRCA genes having targeted therapy, are there other somatic tumor types that have targeted therapies?
There's, off the top of my head in ovarian cancer, there's probably 30 or 40 that we're looking at right now that we can match to therapies. And that, that's a fluid situation, constantly changing. The more information we have, the better we are at taking care of patients.
From Jared Rosa, thank you so much for the excellent presentation and education. Another question for you. Can tumor testing be done at different locations than the site where someone is under care?
So we at Foundation Medicine accept tumor samples from all over the country and actually the world. We do have labs in different locations. Our main site is in Boston or Raleigh, where the specimen would be sent and processed. So yeah, you can essentially have this test done no matter where you live.
And is there something to look for in terms of a good lab for tumor testing? Like how much does the patient choose the lab, or is it really the physician who's picking the lab?
That's a good question. So it's usually provider preference. But, for instance, I first learned about Foundation Medicine from an ovarian cancer patient. And she came in with very specific information that this is the test that she wanted. So, we did our due diligence and research and felt comfortable with ordering the testing. So I think it's completely, if a patient wants to advocate and select their tumor vendor or tumor testing vendor, that's perfectly fine. But yeah, I think the big thing for us is the FDA approval, so then that we can ensure insurance and Medicare coverage for patients.
So it needs to be done in time with a surgery, pretty much.
It does not. It could be a biopsy sample too. So if you have recurrent disease and they do a mental biopsy or a liver biopsy, you can send that sample as well. You can send ascites fluids. We often see ovarian cancer patients that have a lot of ascites, so ascites can be sent as well.
That's good. It's good to know. So it doesn't require surgery necessarily every time. Another question was how long is a tumor preserved for future testing? So like if you had your surgery, how long is that tumor?
That's a great question too. So on average, most pathology labs save it for about 10 years, but some larger academic institutions, usually hold on to things indefinitely. It could be 10, 20, 30 years. So,
okay.
But usually the average is 10 years.
So most likely your tumor is still going to be there for someone to send it off.
Yep.
Okay. I will request that if there's anybody else who has a question, if you could send it in so we can be mindful of Sonja's time. But right now, I think we have answered most of our questions. One question, will most surgeons send to the tumor testing company of your choice when asked?
Yeah, I find that that's, definitely a conversation that providers are open to and would definitely, if that's where you would like your sample sent, that they would follow those.
Okay, a couple more questions. The next one.
Talking, your brain gets.
That's right. Well, that's what happens is somebody says something, you're like, oh, I have another question. Okay, the next question is tumor testing covered by your insurance?
That's a great question. So because we have that FDA approval, we do have Medicare coverage if you meet criteria. And we are working with several insurance partners to ensure coverage for our patients, because I think the most important thing is to have this amazing tool, but we want it to be accessible and affordable to patients. So we definitely are working with our insurance companies. And as we said, we have Medicare coverage. So.
Okay.
And financial assistance. We always, if you are running into situations, we do provide financial assistance as well.
Okay, another question. Sorry, I'm just looking at the questions here.
That's fine.
Is there a need to redo genetic testing after a course of treatment?
Not necessarily genetic testing. Genetic testing, though, with time, sometimes there's updated, they discover different kinds of variations that might have been what we would say a variant of unknown significance might now actually be a actionable or pathogenic mutation. So over time, you could always check back with whomever you had your genetic testing done with to see if they should either complete a new sample, or sometimes they can rerun your old test report and just to see if there's any updates that you would need to be aware of.
Great. I think that we have hit all of the questions that have been asked for now. If there are additional questions out there that people have thought of afterwards, please post them to our site, and we will do our best to reach out to Sonja to help us answer them, because we do want to make this as as informative as possible. I do want to thank you, Sonja, for joining us today and giving us obviously such a detailed explanation of tumor profiling and how it relates to ovarian cancer. I want to thank everybody out there who tuned in and who will tune in and watch this at a later date. I just want to remind you that we do have several more of these coming up. The next couple we have on June 11th, we will have a registered dietitian come and talk about managing chemo-related digestive problems. On June 25th, a gyn-onc will share the latest on maintenance therapies in ovarian cancer. And on July 16th, you can learn how to zentangle, which is a very creative doodle as a form of relaxation. And of course, we always encourage our viewers out there to suggest future programming as well. If you have an idea, put that in the comments as well. So thank you for tuning in, and I hope everybody enjoys the rest of their day.
Thank you for your time.